Hi there, welcome everyone to the fourth session of left ventricular systolic function. We thought we'd show you a couple of cases just to, put a bit of proof in the pudding with things that Chris and I have been talking about in the last few sessions. We have been left to our own devices.
Yeah, so this may or may not be recording, but we'll soon find out.
Yes, it is. All right. Should we overview what we're going to talk through and then show a couple of cases?
Yeah, absolutely. So in the past three sessions on systolic function, we've kind of been going through, intermittently going through some ways of measuring systolic function. And we've really reinforced that in the ICU, this is a journey that the patients go through, and that just a single shot to look at the left ventricle at the beginning of an admission maybe doesn't represent their overall systolic function as a baseline, and that you've really got to see what part of the journey they're on so that you can specifically target their therapy.
Yeah. I want to have a jar so we can put in, I was going to say a penny,
but
$1 for every time we say journey in this podcast.
Yeah, it might be too many. And also, we're only, 6 episodes in, and we've already completely deviated from our planned schedule. So we apologise for that, but maybe we'll get back on track. So
we'll definitely get back on track. Well, these are important concepts to cover early on.
Absolutely, I think so. All right, so I think we've got a few cases. So I think it's your case first.
Yeah, this is a case from a little while ago, actually, I think about a year ago, of a lady in her mid-50s with a history of some alcoholic liver cirrhosis who came to our unit with urosepsis. And this was her echo after some fluid resuscitation. I think she was on some low-dose noradrenaline at this stage. And as we can see, I guess the first thing to demonstrate here, this is the apical 4-chamber view. And we're getting the idea that she's got this hyperdynamic systolic function. You can almost see that there's almost cavity obliteration there. And as you train your eye, you just start to wonder, whenever you see a hyperdynamic ventricle, that's quite a small cavity size, always look to see what that anterior mitral leaflet's doing. And you just get the idea here, the hint here that it's, there's systolic anterior motion of that anterior mitral leaflet. But you would need to slow that down and assess that better. Where do you, I'm going to come back onto that, but just, Chris, where do you assess for, what do you think your best windows for assessing for SAM and dynamic outflow tract obstruction?
My data set always usually starts from the parasternal long axis view. That's normally my home when I start, and usually on my journey through that echo study. So on the parasternal long axis view, you can get really good visualization of the anterior mitral valve leaflet. And firstly, I like to put some color over both the aortic valve and the mitral valve, just to see what the flow parameters in that left ventricle are, and whether there's any AR that's causing MR and things like that. And usually you can see some turbulence there. And then if it wasn't clear that there's SAM from that moment, then you can put M mode through the anterior mitral valve leaflet that can demonstrate that systolic anterior motion in systole, of course. But normally I would be looking in the plaques first, and then, but sometimes I honestly, in an acutely unwell patient, I'll have missed it at that point. And then in, say, the apical 4 or the apical 3, or when I'm doing some LV outflow tract measurements, sometimes I will pick it up there, and then I'll have to go back to the plaques and double check.
Yeah, same. And especially when this patient isn't, but especially when they're so tachycardic. Yeah. If you're not stopping and slowing it down and really looking. Yeah.
That case I showed, the pericardial effusion, the tamponade with the LV outflow tract obstruction, I didn't pick that up on the first plaques. Yeah. It wasn't until I went back and had a look at it that after seeing it in the apical 4 that I went and had another look.
Yeah. So a real take home for me with that would be, whenever you see someone with a hyperdynamic left ventricular systolic function, just go looking. Yeah. Purposefully look for that and train your eye to look for that. So moving on back to this lady. So this was her 2-chamber. We can see again that hyperdynamic systolic function, almost end systolic obliteration. So now we're in the 5-chamber view. I'm just going to slow that down, if I can just pause it here.
We've got some nice lung artifact stopping us from seeing the SAM in half of that loop as well.
Exactly. So I'm just going to bring it back to, so diastole is just finishing. We're just getting into early systole now. And just if you see that, that anterior mitral leaflet just moving towards the septum. So you don't always need to have full septal contact. It can just be moving towards it, or even have brief septal contact to have that outflow obstruction. The next thing would be to put, colour Doppler through that. Do you want to describe what we can see here?
Yeah, so this is, again, a apical 5-chamber view, and we've got a big colour box over here. And you can see that this is using variance, which we talk lots about, the fact we don't really like it. Variance is just showing green colour for high velocity of either direction flow. And in the LV outflow tract here, you can see a huge amount of turbulent flow just proximal to the LV outflow tract. And that's indicative that there might be a degree of LV outflow tract obstruction happening there.
Yeah,
there's also a little bit of aortic regurgitation there.
The next thing, obviously, we would do after colour is lining that flow up with your continuous wave Doppler. So this patient did have evidence of that dynamic left ventricular outflow tract obstruction confirmed on continuous wave. We have that dagger-shaped jet, and we have gradients of, almost 60 millimeters of mercury across that aortic valve. Pretty bad, huh?
It's not very nice.
No, not very nice. If you're seeing this, you can be pretty sure, pretty confident that your patient will be fluid responsive. Obviously, fluid responsive intolerance are slightly different things, which we can get into another time. After you've done your continuous wave through that aortic valve, then you want to do your step-up velocity. And you can either eyeball it and look to see where the turbulence is with colour, but it is, I think, better to use your pulse wave Doppler and find that step-up velocity as well. But this patient had evidence of dynamic outflow tract obstruction as well as mid-cavity obstruction, and we can see, with the pulse wave, we're getting that late peaking, almost sort of stiletto healing feature, of which is classic in mid-cavity, and you don't get the same high gradients. Obviously, this is with pulse wave Doppler as well, so anything above 1.52, you're going to start to get aliasing anyway.
Just to show everyone that you can see the pulse wave Doppler gate here. So this signal is coming exactly from that kind of mid-cavity point, whereas continuous wave will be going throughout the entire line from the apex down to there. And I was always taught to hunt for the gradient in anyone with features that might suggest they've got LV outflow tract obstruction. Someone with LVH or hypertrophic cardiomyopathy, you always have to hunt for that gradient. So walking that pulse wave Doppler gate up and up and up, looking for the possibility of an obstruction, because you can get mid-cavity obstruction, not just in septic shock.
Yeah, so, absolutely. Yeah, really important to... I usually start from the apex, actually, and then sort of work my way down all the way to just behind the aortic valve. Yeah. And there's some lovely profiles you can get here. We're getting slightly off topic, but like the lobster claw in apical Holcomb and all of that sort of kind of thing, where you've got that afterload mismatch, which we can talk through another time. I did want to air my dirty laundry in public with this one, actually, Chris. So again, this is, I think I'd step down from the mid-cavity to just behind the aortic valve, and a couple of things to point out here. Obviously, we're getting that spectral broadening that we talked about, I think, in the cardiac output session, because we've got such turbulent flow coming through. You can see it's all fuzzy. You haven't got that lovely delineation between that dark centre and the modal velocity on the outside. So this is a really nice demonstration of spectral broadening. I also want to point out that the velocity is, reaching more than 2 meters per second, and the reason that it's not wrapped around an earliest is because it's actually flipped to the high pulse.
High pulse repetition frequency.
High pulse repetition frequency, and so it's given me this ghosting gate here. Which you should obviously try to avoid, because you get then a bit of ambiguity in where you're sampling from. So far, the systolic function looks like it's probably working too well. I mean, if we're talking ejection fraction, it's definitely above 75-80%, probably higher than that. Definitely someone who is working a little bit too hard, not playing that high score game of getting the highest ejection fraction we can. It's not a good thing for our patient when we see that. Absolutely, yeah. So I guess in summary, we've got septic shock, vasoplegia, hyperdynamic left ventricular systolic function with evidence of dynamic left ventricular outflow obstruction, as well as some mid-cavity obstruction. So this lady was then, she was given a little bit more fluid after that, and then her vasopressors really started to escalate. So this is the next day when she was on 35 mils of double-strength noradrenaline, vasopressin, and methylene blue. And now what we have is significantly impaired LV systolic function because we have altered her loading conditions. This is that lovely demonstration of when you know, that journey, I'm going to say that again, that journey, you know, for the cardiovascular journey of the patient. And, you know, when they initially come in, they're often very vasoplegic. We then give them, you know, noradrenaline and agents like what we've given this lady to increase their afterload to try to improve their MAP. But what we then do is unmask the underlying septic cardiomyopathy and left ventricular systolic dysfunction. Compared to yesterday, you know, literally the day before, we've now got significant, you know, LV systolic impairment. She also, interestingly, didn't have dynamic left ventricular outflow tract obstruction.
Fix one problem.
Again, fix one problem, but yes. And we do a passive leg raise, and she had no response to that. So her LVOT, VTI, it's probably not perfect, is it? It's not perfectly aligned, but we have got the closing click on some of them. There's no opening clicks. I think it's reasonable.
And they're all pretty consistent.
And they're all pretty consistent. Yeah. And her LVOT VTI was 12, even with the passive leg raise, it didn't change. You know, it was certainly less than a 5% change. And at this stage, she had a stroke volume of 35 mils and a cardiac index of about 1.9. And you know, based on this, it told us she probably wouldn't, you know, respond to fluid. Her the surrogates of her left atrial pressures and things were also starting to trend up, and we thought she would not benefit from any further volume resuscitation. So we actually started some dobutamine, which I haven't got the images showing that, but she didn't have much recruitability, actually, this lady. And I think her, you know, combination of liver cirrhosis with sepsis was a little bit too much for her to overcome. But I think it is a nice demonstration of the rapid changes that we see, as I said.
And trying to target our therapy.
And targeting therapy as best we can.
And
the thing is, you're not always going to get it right, but the good thing is that you can repeat, and if you're not winning, then you sort of change tack and see how you're going. Yeah. Have you got a case for us now?
I do have a case for us. So this, let me make sure our images are working. So this is, I won't show the pictures yet. So this was a 80-year-old who came in to hospital this week, actually, and he presented with a reduced level of consciousness. He had a GCS of 3-4 in the emergency department. He was intubated. He was febrile. He had a bit of the sepsis, of course, like everyone does. And we went down to see him because he needed to come to ICU because he was intubated. We went down to see him. He was pretty cold peripherally. He was now on about 10, 15 mils an hour of metaraminol. We put a central line, arterial line in him, but he was cool up to above his elbows. The noradrenaline was climbing. And the question was, is this the right drug for this patient? You know, where he's cool peripherally, there must be something else going on. We don't really know much information about this patient at this point. We don't know whether he's got long-standing cardiac dysfunction or not. So as like most of our patients, he's got terrible parasternal windows, terrible apical windows. And so the only real window we can get is a subcostal window. So this is a subcostal 4-chamber view.
Yikes.
Yeah, I know. And so this is someone who's got really severely impaired biventricular function. You know, both right and left are down. That LV doesn't look good at all. It all looks pretty global. There's clearly some calcification of the mitral valve as well, but you know, at this point, it seems to be opening well. We can investigate that at a later point. And because he had no apical views, we couldn't get that LV outflow tract view. So we couldn't get a LVOT VTI. We couldn't get estimates of his stroke volume or cardiac output. But as we mentioned previously, you can actually use the RVOT trace. So this is a guy who had very good subcostal views. So we can get very good subcostal short axis views. So this is, although it looks like a parasternal long axis view, this is actually a subcostal short axis view at the level of the papillary muscles. And again, this is showing pretty awful contractility. But then if you tilt the probe up to where the aortic valve is, then you can start to open up that right ventricular outflow tract. And if you go to the next image, so you can sometimes get this all in one, but wasn't able to in this case. But what you've got there is really nice alignment of the RVR outflow tract in the main pulmonary artery.
It doesn't get much better than that, actually.
No. So
I'll just point that out for
yeah.
everyone. So we've got the RVOT here, the pulmonary valve, your main pulmonary artery, and then your left and right branches.
Yeah. And so placing the pulse wave Doppler trace at the level of the pulmonary valve, and we can get an RVOT VTI. So we use that as a surrogate marker instead of using the LVOT VTI. So remember last time we talked about the fact that a normal RVOT VTI was maybe 16-ish. Mm-hmm. And so this is clearly significantly impaired. So we knew with this guy that we were ramping up his noradrenaline. We were giving him loads of afterload. His LV function was bad. Whether or not that was new or old, we don't know. We don't know whether he's got any kind of myocardial recruitability or any reserve in that. But what we did know was that more noradrenaline was probably not the right answer. Mm-hmm. Definitely not any more fluid in this case. And so we started some inotropy for him. So he got a bit of milrinone because he had raised pulmonary pressures as well on his TR Vmax, and his RV was down as well. So we thought a bit of inotropy, and then we'll balance out that vasodilation you get with the milrinone. And so the next day we come in, he's opened up a little bit, he's a bit warmer, his lactate's come down.
What was the dose of milrinone?
So he was on 0.2 of milrinone because his renal function was very poor, so we started low. And then he was on about, I think, 20 mils an hour of single strength noradrenaline also at this point. So day 2 echo, again, very poor views, but immediately you can see that he clearly did have some myocardial recruitability, and his contractility, whilst it doesn't look perfect, it's definitely doing a lot more, both the right side and the left side. The right side looks a little bit less dilated as well, which is a really nice thing to see. And so once again, we could do the RV outflow tract VTI. Let me just move on to that. There we go. So now the RV outflow tract VTI has incremented from around 7-ish to about 12 to 13. So whilst we can't get the cardiac output, the actual numbers, the images aren't good enough to get the RV outflow tract diameter, but we have seen that there's been an increase in that RVOT VTI, so we know that we're getting better cardiac output. So given that it looked like he was working quite hard, his vasopressor requirement had gone up slightly, we started to back away a little bit on that milrinone, just reduce it down to 0.15, and with that, the noradrenaline requirement came back down as well. And by the next morning, the lactate had normalized. We'd basically weaned everything off. He was really warm peripherally, and then we did a day 3 echo as well, and we did another VTI. So I guess this is just showing, I think one's just showing the subcostal short axis in a slightly better view. This guy was now on lower pressure ventilation. He was left lateral now that he was a bit more stable.
We've got the left atrium here, intraatrial septum here, right atrium, we can see the tricuspid valve, and this the right ventricular outflow tract here, and the pulmonary valve with your main pulmonary artery, left and right pulmonary arteries. And it's lovely, and you can get so much information from this, Chris, with even pulse wave Doppler through to get your RVOT VTI. You can also do things like the acceleration time to get a feel for pulmonary vascular resistance and pulmonary pressures. Sometimes you can align your TR jet nicely as well for your pulmonary artery systolic pressures.
Jets,
you can do your bubble study looking for right to left shunt, which is really important in patients with sort of ARDS or whatever. 20% of them, will have that PFO and that right to left shunting. And sometimes you can line up your transaortic flow to get gradients across the aortic valve.
Yeah.
So there's so much information from this one view. It's lovely.
And so a day 3 RVOT VTI, again, just using the same view, the same measure, you can see that it's now come up to around 16. So, and now this is off any support. So this is someone who we've been able to...
That was day 3.
That was day 3.
Wow,
that was
that's
day 3.
Lovely, isn't it?
So this is a really dramatic, very rapid change in someone's cardiac performance, definitely in their cardiac output, and that was mirrored by an improvement in his physiology as well. So we have someone who we are escalating, going the wrong way, and now we've been able to give that targeted therapy, stop giving the wrong drug, and now everything's been able to back off.
Yeah. Did you so with his ventilation? How did you sort of
optimize
that as well?
His ventilation, because he had evidence of RV dysfunction and he had raised pulmonary pressures, we treated him with kind of a RV protective ventilation modes, and really our target parameters for his respiratory markers were different than the normal patient. So we tried to maintain spontaneous ventilation as much as possible, use a slightly lower PEEP strategy. We aimed for a normal pH, aimed for normal capnia, and aimed for a saturation slightly higher than, say, normal 88 to 92. We aimed for above 94 for him, just to try and minimize any further risk to that right ventricle.
Yeah, so everything you can to minimize PVR,
yeah,
and optimize RV contractility. It's lovely.
Mm.
And he had, it's not often you see it, I must say, as dramatic as that.
No.
But that was really nice. It's a lovely example, I think, Chris, of that individualised targeted therapy, which is really the whole point of critical care echo, isn't it?
Yeah.
And, you know, seeing that all of the things that you mentioned, he was shut down, there's clearly a cardiogenic element, let's start some milrinone, you know, have a little bit of Noradon to counteract the drop in SVR, and then everything to try and minimise the PVR. And, it's really
and
nice
people do argue, you know, he had cool peripheries, he was behaving like someone who you weren't winning with conventional vasopressors, and you know, people do have that clinical acumen to make those changes, but we do see it all the time where people have been things are escalating the wrong way and these things aren't picked up. And I guess the other thing to say about a case like this, you know, this person clearly had some recruitability, some myocardial reserve, and we managed to augment their cardiac output with just some very simple interventions and changes. But you may have people come in who have severely impaired biventricular function. They clearly are behaving in a cardiogenic shock type way, and you start them on things, and echo can also show a lack of response. And these are people who you may want to be looking to refer early to transplant centres, or for consideration of kind of VA ECMO as a bridge to kind of VADS or transplant, or of course to recovery. So it's important to be able to identify the people who aren't getting better despite you making changes, and taking echo pictures is a great way to help your referral as well to these places. You know, you can send them a picture of what's going on, and immediately they can have that conversation with the multidisciplinary team over that.
Yeah, I mean, I'm completely biased, but I must admit, looking after any, you know, sick patient, any hemodynamically unstable patient, I just feel like I'm flying blind now. If I don't have the echo out and I'm not sort of trending things, it really does feel like that once you get used to using it.
Yeah, me too. But maybe it's because I've been brought up through my training using echo more and more, but I definitely it's definitely a crutch for me. And
this is an extension of your sort of clinical assessment, isn't it, of the circulatory system. Did you think about putting a PA catheter in? I suppose that's the other. I did think about putting it in. I think these are the people who often will require some kind of cardiac output monitoring. I think if he hadn't been improving, then I probably would have gone down that route. Yeah.
Here, our main cardiac output monitor is a pulmonary artery catheter. Lots of other places have different opinions and have different devices, but definitely, you know, if his catecholamines was still continuing to escalate, if we weren't winning, if his lactate was going off, then definitely I'd have done some cardiac output monitoring, just because we weren't going to be there frequently enough to be able to do RV outflow track traces every 4 hours, like someone doing a cardiac output monitor would.
Yeah. So I guess in summary, Chris, we've shown the two ends of the spectrum with septic cardiomyopathy and why it's sometimes so difficult to define and all of that. We've shown a case where, you know, the patient started off with that hyperdynamic sort of profile and dynamic outflow obstruction, and then when you correct the afterload and fluid resuscitate them, etc., they actually unmask that left ventricular systolic dysfunction. And then with your case, we showed sort of the opposite, really. You know, someone with that hypokinetic, low cardiac output state to start with, who thankfully ended up having some recruitability and improved their cardiac output and left and right ventricular systolic function with simple measures as you sort of targeted that. So I think they're really nice, you know, ends of the spectrum.
Yeah, to demonstrate that we need to capture at what point in the journey our patients on. So on that note, I guess we'll leave it there. So thanks for listening, and we'll see you next time.
Thank you, guys. Bye.